So now we're going to talk about the classification and treatment of Monteggia-like lesions and transolecranon fractures. This presentation is divided into three main parts. First, I'm going to present the current issues related to complex fracture dislocation of the proximal ulna and radius. Second, we will discuss a comprehensive classification proposed some years ago by our group. And lastly, we'll talk about the main steps of surgical treatment. This type of complex injuries are rare, and for this reason they are difficult to treat. Unsatisfactory results and a higher rate of reinterventions are still described in the current literature. Many different classification systems have been proposed in the last century for these injuries. However, these are often incomplete, making it even difficult to define what a Monteggia-like lesion is and what a transolecranon fracture actually is, and leaving us with some injuries patterns that are impossible to classify. What's more, these classifications have a limited therapeutic and prognostic value. So, in 2011, we proposed a new comprehensive classification of this type of injuries to include any patterns that we can observe in our clinical practice and to provide a therapeutic protocol. The issue was to find a definition that included every injury pattern. We defined as fracture dislocation of the proximal ulna and radius, any ulnar fracture associated with isolated dislocation or multiple dislocations of the elbow joints. And to be included in this definition, the ulna had to be totally fractured to distinguish it from other conditions in which only a small portion of the proximal ulna is fractured. The second point was to identify the main lesions that influence the treatment and prognosis of these lesions. We identified 6 main factors, and these are the ulnar fracture level, the presence of one or more elbow joint dislocation, the presence of longitudinal instability of the forearm, and the presence of associated radial fractures. To properly classify each injury pattern of the fracture dislocation with our classification, we have to consider the diagnostic steps shown in the slide. In particular, X-rays, CT scans, and intraoperative fluoroscopy evaluation are the most important exams to recognize all bone and soft tissue lesions. So this is our classification, and as you can see, it is based on alphanumeric code. It is actually much easier to understand than it looks. You just have to answer to the following 4 questions. First, what kind of ulnar fracture do we have? Second, which of the 3 joints of the elbow are involved? Is there a radial head fracture? Are interosseous membrane and distal radial nerve joint lesions associated? And by answering these 4 questions, we can identify the main lesions and, of course, choose the optimal treatment. It's important to distinguish these 3 main types of ulnar fractures. Type 1 fractures are proximal to coronoid process. These include olecranon fractures involving the articular surface, entailing a loss of posterior osseous stability and possible loss of ulnar humeral congruency. In this fracture, the coronoid process is intact. In type 2, fractures are distal to the coronoid. And these include shaft fractures, which may cause angular, translational, and torsional deformities. And in these fractures, the coronoid is intact. In type 3, the fracture is at the level of the coronoid process. So this is a metaphyseal fracture with articular and ligamentous damage. The fracture, particularly when extending to the zones of ligament insertion, like the supinator crest and the sublime tubercle, may cause a loss of anterior, medial, or lateral stability of the elbow. In many cases, these 3 main types are associated between them, and so we can observe type 4, 5, and 6 ulnar fractures, the latter being the most complex. Now we have to clarify that these ulnar fractures can be associated with 2 main types of joint lesions that we classified into type A and type B. Type A lesions are characterized by the integrity of the proximal radial ulnar joint. Here, collateral ligaments are generally not involved. These must be distinguished from type B lesions, the so-called Monteggia-like lesion, which is a very heterogeneous group. And we have to remember that type B lesions are often associated with ligament injuries. In fact, in another study of our group about ligament lesion in complex elbow instability, differences in ligament involvement between type A and B were clearly observed. Now let's analyze every single subgroup of type A lesions. In type A first, the forearm is dislocated anteriorly. And as you can observe, the relationship between the radial head and lesser sigmoid notch is preserved. This is an anterior transolecranon fracture dislocation where ligaments are rarely injured. This is a type A second lesion in which the forearm is dislocated posteriorly. This is a posterior transolecranon fracture dislocation, and again here collateral ligaments are rarely injured. These are the three subgroups of B lesions characterized by the direction of the radius dislocation. These are radial ulnar joint dislocation with proximal radio-ulnar dislocation with olecranon or metaphyseal diaphyseal ulnar fracture. The key point in B lesions is the involvement of the proximal radio-ulnar joint, and that means that different soft tissue stabilizers are injured. These lesions are frequently associated with diaphyseal and metaphyseal ulnar fractures and radial head fractures. They may also be associated with interosseous membrane and distal radial ulnar joint lesions. Regarding radial head fractures associated with this type of injuries, this type of classification is useful in clinical practice, giving us a therapeutic algorithm. We should remember that the proper surgical treatment of radial fractures significantly affects the prognosis, and we should remember that radial head resection is contraindicated in fracture dislocations of the proximal ulna and radius. Rarely, we can observe a longitudinal instability of the forearm. For this reason, we have introduced the lesions in our comprehensive classification. These lesions should always be identified because the results are terrible if left untreated, such as the chronic Essex-Lopresti lesion. And finally, do not forget this complex pattern of fracture dislocation, which we call the E lesion. And this is characterized by severe elbow instability with involvement of LCL, MCL, anterior and posterior capsule. Frequently, this is associated with a plurifragmentary diaphyseal ulnar fracture, and in this situation, after ulnar and radial internal fixation, a careful reconstruction of collateral ligaments is necessary. For this reason, we included this lesion in our classification to stress the association with a complete elbow dislocation. And now we can start to discuss how to treat these lesions. The main goal of the treatment is to recognize and treat every single lesion of our fracture dislocation. And we want to achieve an adequate articular reconstruction and to recover the elbow stability. In our study, we proposed a detailed therapeutic protocol. Each type of lesion has a correlation with a specific aim of treatment and type of surgery. So, for example, in type 1 olecranon fractures, the aim of treatment is to restore the greater sigmoid notch, while in type 2 diaphyseal ulnar fracture, it's represented by the restoration of the ulnar length, alignment, and rotation. In both cases, ORIF with the plate is indicated to obtain these goals, and so on for the other type of lesions. Now I'd like to show you some examples based on this classification. This is a classic transolecranon fracture dislocation in which the proximal radial ulnar joint is preserved. In our classification, this is a type 1A first. It was treated with a posterior plate and bone graft to fill the posterior gap, and ligaments were intact here. Now, let's see this very complex case that we can classify as type 5, B third, and C third, as shown in the pictures. This is a Monteggia-like lesion with the involvement of the proximal radial ulnar joint and also of the collateral ligaments. In this situation, we performed an ulnar plate fixation, and we also used the fine threaded wires with particular attention to the coronoid osteosynthesis. After that, a radial head replacement was performed as the radial head was not reconstructible, and a repair of the lateral collateral ligament was performed with a suture anchor. This is another case of a typical Monteggia-like lesion that we classified as a type 3B second because there's a metaphyseal fracture associated with a lateral radial head dislocation. In this case, we performed an ulnar osteosynthesis with a plate and repaired the LCL with a suture anchor. And this is a clinical outcome after 4 months. This is a case classified as type 4, B third and C first, in which the ulnar fracture was treated with a low-profile posterolateral and posteromedial plates because the skin was damaged. In these cases, posterior plates should be avoided. Finally, I'd like to show you this difficult case in which we applied an external hinged fixator to protect the construction of bony and ligamentous structures. The small size of the fracture fragments and the poor quality of the ligaments were the reason to apply the DJD. In conclusion, I'd like to share with you what we call the rule of the 7 principles in complex elbow instability. This is what we have learned in the last 20 years. As you can see, the restoration of the ulnohumeral joint is of paramount importance, as well as the reconstruction of the lateral-collateral ligament complex. MCL should be repaired in case of persistent instability after LCL repair, and an external fixator should be positioned if the elbow continues to be unstable. Thank you very much for your attention.